Chief.
My lady, the next witness is Samunia Mohammed. If he could be sworn, please.
Right, repeat after me. I do solemnly,
I do solemnly,
sincerely and truly
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the
and
truth.
nothing but the truth.
Can I sit down?
I hope you were told you wouldn't be on until this afternoon.
Yeah.
Samunia, could you commence your evidence, please, by giving us your full name?
Munir bin Mohammed.
Thank you for attending today and also for your provision of your witness statement, which is dated the 5th of September 2024, including a large number of exhibits, all of which, of course, has been very carefully looked at by the inquiry and will continue to be so. By way of background, please, and your qualifications and experience, Samunia, you qualified in medicine, did you not, from the University of Liverpool in July '85. You've undertaken clinical work in the NHS for many years. You're a consultant physician. But you first joined the Commission on Human Medicines in 1996, is that right?
I joined one of the expert working group, which was a pharmacovigilance expert advisory group in 1996.
All right. When you give your answers, could you try to go as slow as you can? It simply makes the task a bit easier for our hard-working stenographer. Thank you. You have carried out a vast amount of research in the field of the safety of medicines. I think you've published over 660 academic papers in that area. You are a renowned clinical academic researcher and you hold the David Weatherall Chair of Medicine at the University of Liverpool and a number of other chairs. Is that right? In particular, in the field of pharmacogenetics.
That's right.
Having, as you say, joined the Pharmacovigilance Expert Working Group in 1996, did you become a member of the Commission on Human Medicines in January 2020?
That is correct.
And were you appointed the chair of that body on the 12th of February 21 for a 4-year term?
That's correct.
So you're still in harness. We've heard a considerable amount of evidence about the expert working groups which form part of the Commission on Human Medicines. During COVID, were you a member of 3 of those expert working groups, the Vaccine Safety Surveillance Methodologies Expert Working Group, the Vaccine Benefit Risk Expert Working Group, and the Therapeutics Expert Working Group?
That is correct. I chaired the Vaccine Benefit Risk Expert Working Group.
The Commission on Human Medicines is obviously a statutory body because it was established by the Human Medicines Regulations 2012. But how long had its predecessor statutory body been around for? And before then, how long had the ad hoc committee dealing with giving advice on the safety of medicines been around for?
So the first committee was set up after the thalidomide disaster, which was in 1964. It was the Committee on Safety of Drugs, which was called the Dunlop Committee. This was then succeeded by the Committee on Safety of Medicines. And then 2005, this was then changed to the Commission on Human Medicines.
Was the yellow card scheme first introduced at the time of the Dunlop Committee?
It was.
So it's been around for a very long time.
Long time, yeah. 70 years last year.
And in very general terms, do the functions of the Commission on Human Medicines extend to looking at safety with a high degree of exactitude in the context of the clinical trial process, the authorization process, the process by which the MHRA authorizes therapeutics and vaccines, medicines, but also post-authorization? So from the very beginning of the process by which any medicine is developed to right to the end of the process, years after it may have been authorized.
That is correct.
Is it operationally independent of the MHRA, the JCVI, the DHSE, and all the other myriad bodies of which we've heard?
Yes, it is an independent body, and it's important that it remains an independent body.
I think your secretariat is provided by the MHRA, but is the CHM, I'm going to use the acronym from now on, operationally and functionally completely independent from the MHRA? You don't adopt its advice, you won't necessarily take the same position as it will, and it has no influence on any of your thinking.
Yes, it is independent. We get the secretariat from the MHRA, but it is independent and provides advice as an independent body to the MHRA or the Secretary of State.
And formally, you give advice, do you not, to the MHRA, and where there is a licensing minister in place as the licensing authority, which is what the MHRA is ordinarily, to the licensing minister as well.
That's correct.
During the course of the pandemic, did the MHRA and or the licensing minister, and I think there were a number of licensing ministers during the course of the pandemic, follow the advice given by the CHM?
Yes, they followed all the advice that was given by CHM. I do not know of any incident where CHM advice was not followed.
You're subject, I think, to a very strict code of practice. Is that right?
That's correct.
And do we see, and we'll see perhaps in a moment, that in the course of every CHM meeting, there are long pages devoted to every single individual member of the committee, declaring relevant connections and links, and also at the end of the meeting minutes, again, a long list of declarations of links, personal, non-personal, specific, non-specific, and so on.
That is correct.
In terms of the devolved administrations, Samina, is the CHM UK-wide?
It is UK-wide.
So it gives advice to the MHRA, which is itself a statutory body,
Yeah.
which has UK remit. And did you happen to have a close working relationship with representatives of the devolved administrations?
So we advised the MHRA. We did have representatives from the devolved nations attending some of our meetings as observers.
So not as members, but as observers.
As observers.
And were those observers from, in England, the NHSE and PHE, UXA, Scotland, Public Health Wales, and the Health and Social Care Committee, is it, in Northern Ireland?
That's correct, as well as JCVI.
And JCVI. All right. Give us, please, some scale of the degree of work and attention paid to the issue of vaccine safety. Roughly, how many times did the vaccine benefit risk expert working group meet between 2020 and 2023?
There were 93 formal meetings, but there were other meetings in between as well. So I would expect that we probably met more than 100 times overall.
We needn't, I think, spend any time looking at the role of the CHM in the course of the clinical trial process. We've looked at the clinical trial procedures from a number of different angles already. So we can focus on the introduction of of the CHM's input from the moment of authorization onwards. But presumably, prior to authorization being granted in the case of each of the 3 COVID-19 UK vaccines, the CHM was very well aware of the nature of the vaccines in each case, the clinical position, safety-related issues, really everything to do with their development and production, because you were involved from the very start.
That's right. So obviously the rolling review that happened was very important in order for us to be able to look at the data that was coming in with regard to efficacy, but we spent a lot of time on the quality, particularly at the beginning, because if you don't have a product which is of good enough quality, then it won't go through the authorization process. But then when the safety issues also start coming through, we were able to look at that as part of the rolling review.
Coming forward to the 8th of December, the Pfizer vaccine had been authorized on the 2nd, and the first vaccination was given to Mrs. Keenan.
Yep.
on the 8th. When the Pfizer vaccine was rolled out on that first day, was there, at the moment that the programme started, a 15-minute observation period?
There wasn't when the first vaccine was given.
What happened on that night, the first day of the programme?
So there were two reports of anaphylaxis on the first day, and I got a phone call at 1:45 saying that we need to meet now to be able to discuss what happened and what are we going to do to be able to make sure the vaccination program can continue, but ensure that we monitor the safety of the vaccines and ensure there's mitigation in case of further cases occur.
Were you able that night to establish whether there was any link other than temporal between the occurrence, the incidence of anaphylaxis and the receipt of the Pfizer vaccine?
Obviously, anaphylaxis, by definition, is an adverse event which occurs very soon after administration of a medicine, such as a vaccine. So from that, we were able to assess that temporal relationship, and it was clear that these individuals who had developed the reaction had a complex history, but nevertheless, we felt that the vaccine was probably responsible, and therefore we then instituted changes to the drug label, to the product information, patient information leaflet, as well as introduced a 15-minute waiting time after vaccination.
Overnight?
Overnight.
So that when vaccination continued in the morning,
Yeah.
the up-to-date position was being given to the public as well as the clinicians or the vaccinators.
Yeah. I should also say that on the next day, we got together with experts in immunology, allergy, and brought them together to get further advice in terms of making sure that we were looking after the risk associated with the vaccine in terms of anaphylaxis.
It was no small matter to introduce a 50-minute observation time because presumably there was a huge impact in terms of the arrangements that were being made in every single vaccination site.
Absolutely, because all the processes which have been developed in the weeks before the first vaccine was authorized was all based on getting large numbers through. But then when you have a 15-minute waiting time, you need more space in the waiting room, and your throughput actually goes down.
So you were concerned about slowing down the rollout by doing this. Were there also concerns about whether or not, by requiring everyone to wait for 15 minutes, you would inadvertently add to the risk of transmission in vaccination sites?
Absolutely, and we discussed all the risks associated with our 15-minute period, particularly with people in close contact with each other in a small waiting room, and the increased risk of transmission, but also the reduction in throughput.
But regardless of those concerns, you thought, and you advised accordingly, that the right thing to do was to introduce this observation period nevertheless.
Absolutely, we felt it was important for the safety of the people who were being vaccinated. As we got more data, and you may want to go through that later, we were able to relax that 15-minute.
So during the booster campaign, 2022, the 15-minute observation period was removed, was it not?
Yes, we said we would remove it, first of all, for anybody who'd had 2 doses of the mRNA vaccine, and therefore for them to get anaphylaxis on the 3rd dose would be extremely unlikely, so we removed it for the 15-minute period for them first, and then we got further data later on, and we removed it for other people getting vaccines for the first time. But at the same time, we asked the UKHSA as well as NHS England to provide us with data to make sure there were no adverse incidents occurring and the patient safety was paramount at all times.
Having said we wouldn't look at the clinical trials, there is one area that I wanted to ask you about. I apologise. It's a matter of particular concern to many people, but in particular some of the core participant groups in this process, as to whether there was sufficient diversity in the clinical trial process for the COVID-19 UK vaccines. The Commission on Human Medicines is not directly responsible for the setting up of trials. It appears to be a process which has many parents in terms of the manufacturers, the funders, government bodies, and the MHRA. So to what extent did the Commission on Human Medicines express views on the diversity of the clinical trials as they were ongoing?
So when we looked at the data through the rolling review, we were able to look at the diversity aspects of the trials which have been undertaken. And by diversity, not only ethnicity, but also sex, but also age as well. And importantly, to make sure the elderly, who were the most vulnerable, were included in the trials.
And why, in general terms, is it important for the CHN to express views on the diversity of particular sectoral groups, whether it be defined by age or sex or ethnicity?
It's important because we want to make sure that the vaccine is going to be effective equally in the whole of the population that is present in the United Kingdom. If there was a particular group which was not included, then it is possible that we may, at the time of licensing, advise the MHRA that that particular group should be excluded from receiving their vaccines. For example, for the Valneva vaccine, which came later on, there wasn't enough evidence for over 65, so we actually just licensed it for under 65s.
So issues of width of diversity are directly linked to, firstly, whether or not authorization will be given for a particular sector or age, and secondly, any conditions that might be imposed on the grant of authorization subsequently.
That's right. We will always give advice on a particular medicine or vaccine based on the clinical trial population that was included in the pivotal trial.
And did you have access to data on diversity for those trials that were physically taking place in the United Kingdom? And AstraZeneca had at least 2 trials, COV1 and 2, in the United Kingdom,
Yeah.
or trials globally?
Yes, we had data on age, sex, and the ethnic characteristics as well of the participants.
From everywhere in the world where the trials were being conducted, or just the United Kingdom?
So, because most of the trials which were undertaken were international, we did ask for all the data from all the different trials.
And did you get it?
Yes. And I should say, sorry, it was published as well when the papers were published in the New England Journal of Medicine or Lancet, very respectable journals. The data on the groups which were included in the trials was published in those papers.
Yes, we've seen the Lancet article, including the AstraZeneca data, published, I think, in December 2020. Presumably, the data which you sought and you were provided with included not just data on diversity, but data in relation to those cohorts of people who were excluded necessarily from the trials on account of the risk or because it was obvious that they wouldn't benefit from trials and therefore wouldn't benefit from vaccines.
Absolutely. And this is where the risk management plan comes in, where there's data not available in a particular group, for example, the immunosuppressed or immunocompromised individuals, for example, people with HIV, and so on. So it was important for us to be able to identify where there was missing information, and that becomes part of the risk management plan to ensure there's post-authorization commitments to get that data for the future.
Turning now to the procedures and the processes which were in place for the CHM to be able to advise on safety. Could we look, please, at INQ 000274036? This is a report dated the 5th of February 21, or at least it was published on the 5th of February 21. It's a document that comes from one of the expert working groups, the Vaccine Safety Surveillance Working Group of the Commission on Human Medicines, and therefore is concerned with safety surveillance. If we look at it, and perhaps we'll just go to page 2 or 3, we'll see, not 2 then, 3, thank you very much. The document refers to the background, obviously the emergence of the vaccines and their authorization, and then at the bottom of that page, the need for post-authorization vigilance. It sets out in very large part, the MHRA's own working practices relating to pharmacovigilance, in particular, what we now know to be the 4 pillars of the MHRA's pharmacovigilance system. Why was it necessary for the CHM expert working group to be opining upon the nature of the MHRA's pharmacovigilance system? I mean, you could not be unaware of it. I mean, you must know this issue like the back of your hand. Why was the working group concerning itself with reporting on this?
So very early on in the pandemic, if a vaccine was going to become available, we knew that we would have to vaccinate millions of people. So it was important to have a very robust plan in place to ensure that we could monitor the safety of the vaccine. So the MHRA, this expert working group was set up really with experts in all sorts of fields to advise the MHRA on what those 4 pillars should be and the necessary requirements for those 4 pillars.
So the MHRA changed its working practices in the course of the pandemic, or at least at the beginning of the pandemic, on advice in part from the Commission on Human Medicines in order to tighten up and improve, insofar as it could be improved, the pharmacovigilance system.
Yeah, so for the other vaccines which have been authorized before the pandemic, some of these processes were already in place, but in this particular area, the 4 processes were brought together so that we could have the most robust, proactive pharmacovigilance system.
Part of one of the 4 pillars is the yellow card scheme, is it not? You've told us that that had been long established. It had been first commenced in 1964. Is it a scheme that's run by the MHRA or the CHM or both?
It's both. It's part of, when it was set up, it was under the aegis of the regulatory agency at that time, which wasn't called the MHRA, and the CSM.
We've heard evidence that in May 2020, a dedicated portal was set up to report COVID-related adverse events. Was that in part because of the report from the CHM's working group, or was that something that was already envisaged and brought into play?
So the portal was set up, as far as I can remember, largely to help people to be able to report. It was very important to make sure that people were aware of it and report through a particular portal to recognize when they had the COVID vaccines or COVID therapeutics. There was the other portal, which is for the other medicines, which will continue at the same time. In the end, they all went in the same database, and using statistical techniques, you can identify which are the COVID-related reports compared to the non-COVID-related reports.
Can you please tell us what the broad benefits are, or the broad purposes are of the yellow card scheme? Firstly, it's obvious that when a reporter submits a report through the yellow card scheme online or on paper, that person brings to the attention of the MHRA and the CHM the actuality of a possible adverse event. They're telling you about something that's happened. How important is it, though, also for the CHM and the MHRA to understand the perspective from the patient as to what they believe has occurred to them?
So if you look at the yellow card scheme from the time it was set up in 1964, it's evolved quite a lot. Initially, it was set up for doctors, dentists, and coroners. And then work was undertaken by one of my predecessors as chair of the Commission on Medicines, looking at pharmacist reporting, and that then introduced pharmacists to be able to report the yellow card scheme. I then undertook a study in nurses and then produced the evidence that enabled the nurses to start reporting, and then there was another report and work done on patients. And all those different groups can provide valuable data to the overall scheme, but they come from different perspectives. And that's part of the richness of data that we receive in the yellow card scheme, which allows us to be able to assess potential signals of adverse reactions.
And if a reporter makes a report and tells you about a possible or suspected adverse event, is the scheme designed so that you can, or somebody in the MHRA can, request additional information either from the reporter or from the GP, primary care or the hospital secondary care?
Yes, absolutely. So that is very important because the amount of information received in different yellow cards from different people varies and the quality varies. So it is important to ensure that we can get as much as information as possible, particularly when you are reporting serious adverse reactions.
And presumably the database and the software to which you've already referred crunches all the events, the reports, all the associated information. I'll come back to what additional information you can get, crunches it and tells you whether or not there is a significant identifiable trend in terms of a particular adverse event.
That's right. So there are various statistical techniques, and they've been covered by other expert reports in terms of how you can actually identify potential signals which are occurring for the large numbers of reports that are received.
Do you, on the back of a yellow card report, go directly to the manufacturer and say, what's this about? What's happened?
So the yellow card system is a signal generating system. There's a potential signal arising. Further work then has to be undertaken to determine whether the signal is a true signal or a false signal, in which case the advice from the CHM to the MHRA might be that you do need to go to the manufacturer for them to be able to undertake further evaluation. And the manufacturer may have reports from all over the world, which the MHRA may not have. So to be able to provide us with the overall totality of data in the global population, for example.
And what proportion during COVID of the yellow card reports related to reactogenic injury, that is to say, injection site reactions?
The majority of the reports that we received were reactogenic events.
Was there a proportion of the yellow card reports that were, to use the expression in your statement, placebo-related?
So obviously, the yellow card scheme is designed to report suspected. There's no determination of causality from individual reports, but studies have been undertaken since then and systematic reviews and meta-analysis, which have highlighted that of all the reactogenic events which have been reported, at least 2/3 are probably nocebo effects, while 1/3 are truly related to the vaccine.
And what does that mean, placebo effects?
So nocebo effect is a negative expectation.
Oh, so nocebo, not placebo.
Nocebo effect.
Nocebo.
A placebo is a positive expectation of something's going to work. A nocebo effect is a negative expectation that something is going to cause harm to you.
How easy is it for the CHM and the MHRA to follow up an individual yellow card report in terms of getting access to primary health data, GP's notes, GP observations, treatment, and perhaps more relevantly, hospital notes? So that's notes from treating clinicians and also X-rays or radiographical information.
So on an individual basis, if we get an individual yellow card report, to get more information, one has to contact the reporter. So it becomes hugely resource intensive. Reporters may have moved, doctors may have moved, nurses may have moved. They often don't respond to the MHRA, which means that the process of actually getting more information on individual yellow cards is quite difficult and takes a long time. And the team at the MHRA worked very hard to be able to get as much information as possible from the individual yellow card reports, which was hugely important because some of the data which was being received did not have enough information. So it was really important that we got as much information as possible so that we could make the right decisions.
And if a reporter did respond and gave you access to their medical records, how difficult was it to get into GP databases and hospital databases to get the clinical information?
So when the reporter does respond, they respond in terms of questions which are asked. They don't give us access to the medical notes. So we don't get access to individual medical case records.
Ever?
No.
All right. Sadly, there were a number of yellow card reports involving death, fatality, where somebody, a member of a family, had reported the death of a loved one through the yellow card system, were all yellow card fatality reports followed up by the MHRA or the CHM by way of going back to the reporter and following it up?
That's correct. Every report which is of a fatality is followed up by the MHRA.
Concerns have been expressed in some of the core participant material as to the liaison between the MHRA and CHM and the coronial system. Are coroners able to report the outcome of inquests directly to the MHRA or CHM, or do they have to go through the yellow card scheme themselves?
So when the yellow card system was set up, it was set up for doctors, dentists, and coroners so they could report via the yellow card system. However, they can also write directly to the MHRA if there are particular concerns. And sometimes, the coroner's report comes to some of the expert advisory groups, such as the Pharmacovigilance Expert Advisory Group, on particular issues.
All right. In terms of, and you have many, many years of experience nationally, internationally, of dealing with systems for the reporting of safety signals and adverse events. How does the yellow card scheme in the United Kingdom compare to its international analogues?
Maybe I'm biased, but I would say it is one of the better ones across the world. There are many systems out there, and many countries have copied the yellow card system once it was set up, but it is perhaps one of the most robust ones. That doesn't mean there is no room for improvement. Any system can be improved.
There appears to be considerable material before the inquiry suggesting that, perhaps surprisingly, a lot of people are simply not aware of the yellow card scheme, or if they're aware of it, don't know how to use it to their best benefit. Putting aside the mechanics, well, I'm not going to ask you about the mechanics of the scheme. Is there anything that could be done, do you think, to raise awareness of the scheme in the public sphere, or to encourage reporting of adverse events or possible adverse events by clinicians?
Sure. So there are many things which have been done in the past to be able to improve reporting. For example, when I was a junior doctor, because this was my area of interest, which is drug safety, I developed a poster which I posted all around the Royal Liverpool Hospital. It says, don't delay report today. And simple things like that can help in terms of improving the reporting from hospitals, for example. But the important thing to do always is to continual reminders to people. You can do an advertising
in the public sphere.
Yeah, that's right. You can do an advertising campaign which leads to a spike of reports, but then within a few weeks it's gone down back to baseline. So it's the continual reminders which become really important.
I don't think His Majesty's Treasury will thank me for asking you this question, but have there in the past been processes, I think in France, where people were paid if they made a yellow card report, and that had the effect of increasing the use of the system, albeit when the process of paying people ended, the figures went back down?
So it was in fact done in Ireland by Professor John Feely. He did a very nice study which he paid people to report, and that led to a spike in reports. But as soon as the payments were withdrawn, the numbers of report went down again.
All right. I think the inquiry's own expert, Professor Stephen Evans, suggested that be prizes awarded to clinicians who first reported on a novel adverse event.
Yes.
How do you ensure they're reliable reports if you're giving someone a financial incentive?
So obviously a robust evaluation was done of those reports, and they were of good quality.
We'll come back to, Sir Munya, the issue of whether or not the data systems in primary and secondary healthcare work well enough in terms of being able to link them, and also in terms of accessibility to the MHRA and CHM at the end. Can we then turn to the question of thrombotic thrombocytopenia syndrome, TTS, blood clots. Thrombotic events were not identified were they as adverse reactions in the course of the clinical trials themselves.
They were not.
But was thrombosis known to be a potential side effect of vaccines historically?
So from other vaccines, it wasn't one of our adverse events of special interest. Thrombocytopenia, which is a lowering of platelets, was one of our adverse events of special interest, but thrombosis per se was not.
All right. And the system of adverse events of special interest, is that the system by which, during the clinical trial process, manufacturers and regulators require the identification of particular safety events or adverse events which may be likely to give rise to problems in the future because historically they've appeared?
Yeah, not only during the clinical trials, but post-authorization as well.
All right. Then in February 2021, the MHRA first started to receive yellow card reports of suspected thrombosis and associated thrombocytopenia. Thrombocytopenia is the low platelet syndrome, isn't it? And those reports were associated with the AstraZeneca vaccine, were they not?
Right.
The expert working group on the 25th of February in the CHM presented a paper on something called immune thrombocytopenic purpura. Is that correct?
That's correct.
Was that in response to the receipt of the yellow card reports?
It was related to the yellow card reports on that particular population. We were focusing on immune thrombocytopenic purpura, but then there was, I think, 3 reports at that time of the occurrence of thrombosis with thrombocytopenia, which was very unusual, and we highlighted that these need to be followed up in more detail and further monitored.
Concurrently, in Europe, from the 11th of March onwards, a number of, not regulators, but health authorities, suspended the deployment of AstraZeneca following the emergence of these reports. In particular, I think there was a lady in Denmark who'd presented a very unusual clinical picture as a result of taking AstraZeneca, or following the receipt of AstraZeneca. And so on the 17th of March, did you convene, or was there convened, your vaccine benefit risk expert working group to look at what should be done about how properly to respond to these emerging reports? We'll look at it, 000409517. We can see a very significant attendance list. There are a lot of people there, aren't there, Saminia? Participants present on the left-hand side. If we go over to page 2, some personal data is redacted, but I think if we could then go over further one page, we can start seeing, thank you very much, the introduction and announcement. There's a reference there, isn't there, to the conflict of interest policy. At the beginning of every single meeting, does the chair remind everybody present, members and participants, of their obligation to declare any financial interests, personal or non-personal, specific or non-specific, which they have or which an immediate family member has, in any of the agenda items?
That's right.
All right. And did some people declare interests, however tangential, in that annex?
Yeah.
If we then go, please, to paragraph 2.5 on page 6, we'll see that the group, having looked at data and the evidence relating to these reports of thrombosis with thrombocytopenia, agreed there was no evidence of an increased risk of peripheral venous thromboembolism. The group also agreed the evidence did not support an increased risk of thrombocytopenia alone. Could you just explain that paragraph to us? But in particular, was the group reaching a view on these particular conditions, or was it reaching a view generally on the risk of thrombotic thrombocytopenia syndrome?
So you can have different clinical presentations there were people who were reporting the occurrence of thrombosis in their legs, a peripheral deep venous thrombosis, for example. But there were other people who just had low platelets without thrombosis, and then there were people who had thrombosis together with the low platelets. And so we had to consider the three groups separately to understand where there was an increased risk. And at that time, in terms of the evidence we had, we concluded there was no evidence of increased risk of peripheral venous thromboembolism and no increased risk of thrombocytopenia alone. However, we highlighted the unusual cases of thrombosis with thrombocytopenia and the need for further follow-up of those cases.
So in relation to that particular type of condition, thrombosis with thrombocytopenia, so blood clots and low platelets, there was something to suggest a problem, an issue, which is why you said further information needs to be rapidly gathered.
That's right. Maybe you can add that in my career, without the vaccines, I think I'd seen one case like that in the past. So this is an extremely rare condition that occurs. And so we were just wanting to know how often it was occurring and why was this just because there was heightened awareness that these cases were being reported.
Can you just please explain the importance of that observation about the extreme rarity of this condition in background, that is to say, in normal day-to-day life? So by comparison, if you're starting to get a number of reports temporarily following vaccination, that's got to be compared against the extreme rarity of it occurring in day-to-day life.
Yeah. So any condition that, unfortunately, any disease that occurs in the human population has a background incidence. And one of the limitations that we had was that we didn't have the data resources available in this country to be able to define what that background incidence was of thrombosis with thrombocytopenia. So that was the first issue. The second issue is that COVID itself can cause thrombosis. COVID itself can cause thrombocytopenia, and it was likely that COVID itself could cause thrombosis and thrombocytopenia together. Again, we do not have much data on that. And so it was important to be able to understand what was going on to determine whether it was truly vaccine-related or related to the underlying disease.
You're the specialist advisor on these, of course, very complex but extraordinarily serious issues. Why was there not available a case definition or at least data as to what the pre-existing position in the community was in relation to this condition? I mean, isn't that the sort of data which should be always available to you so that you can make a careful and rational conclusion as to whether or not these new reports are out of the ordinary?
So there was no case definition available when these reports started appearing, largely because this condition is relatively rare. As I said, in 30 years of clinical practice, I've only seen one case of this in my career. So what we did very quickly was to get expert hematologists together and worked with them to develop that case definition. And I want to thank them for the enormous amount of help that they gave the Commission of Human Medicines and the MHRA in developing that case definition very quickly.
So, I mean, this meeting was on the 17th of March. The first reports of suspected thrombosis and associated thrombocytopenia had first started emerging in Europe, I think in the second week in February. Why could that passage of time between February and March not been used to try to bottom out the case definition or to see what data there was about background incidents?
So as I said, the data was trickling in, and it was incomplete, and we had to keep on going back to the individual reporters, to the hematology community who were gathering more data for us. And so a case definition really needs to be robust to be able to get as much data as possible so that you can have a definition which other people can follow. If you have a case definition which is incomplete, then it will lead to a lot of noise in the system.
The meeting was on the 17th of March. By that stage, I think a number of European member states, I emphasize, not their regulators, so the regulators weren't withdrawing authorization, but their health authorities, and that's Austria, Norway, Iceland, Italy, Estonia, Latvia, Luxembourg, and Lithuania, had suspended the practical deployment of AstraZeneca, if it was good enough, if the concerns and the emergence of this extremely rare condition was good enough for them to put into place a suspension of deployment, why wasn't it good enough for the United Kingdom?
So the vaccination practices were different in those countries compared to the UK. They were vaccinating.
Why was it different?
So they're vaccinating different age groups. We were following the 9 priority groups determined by the JCVI, particularly the vulnerable group and so on, whereas AstraZeneca vaccine was being more used in the younger population in some of the European countries.
And so just to make that point as clear as you can, Saminia, the CHM deduced that because the AstraZeneca vaccine in the United Kingdom was not being used on younger people, because we were still in the priority list of elderly people, there was less risk because this syndrome, TTS, appeared to be more prevalent in younger people from the reports that were emerging from Europe.
So at that time, we had some suggestion it was more prevalent in the younger population, but not good enough data. But that was one of the reasons, and as we were working through the 9 priority groups, it was more being used in the older age groups at that time. And also, I should say that the vaccine availability was different. So obviously in some of the EU countries which were able to stop the AstraZeneca vaccine, they will have looked at what other vaccines were available to continue the vaccination of the population.
At that date, on the 17th of March, had the JCVI issued its phase 2 list, that is to say, the list of people who should be offered vaccination after phase 1, the priority list was complete?
I would have to check on that. I can't remember exact date when they actually produced that.
All right. There were then a number of further meetings. The expert working group met again on the 23rd of March. The vaccine benefit risk expert working group met on the 24th of March. I think you convened an independent panel on the 26th of March with that of haematologists.
That's right.
And then on the 27th of March, the full CHM convened. That's 409, 498. The minutes, again, we can see the attendees on the left-hand side of the page. If we go to page 6, please. This is a Saturday, 27th of March. Paragraph 2.11, the Commission concluded that while there was a temporal association, thank you, between vaccination and reported events, the mechanism had not been confirmed, and thus a causal association with the AstraZeneca vaccine could not be established. So, by now, the 27th of March, almost a month and 3/4 had elapsed from the time of the first reports being received from Europe. Why was it not possible to confirm the mechanism? We presume from that it means the data hadn't been made available that would have established one way or the other whether a causal connection was there. I mean, more weeks had passed. Why was that data not available?
So the data was trickling in. As I said, it was very difficult to get that data. Also, the data linkages that we required to get that data as quickly as possible were just not available.
And what were they? What were those data linkages?
So if you consider, some people have talked at this in this module about triangulation of data. Obviously, if you have a vaccine in a vaccine center, that data then is linked to the primary care record. But then if you develop a serious adverse event, that usually ends up in hospital admission, so you need that triangulation to the hospital data. But even within hospitals, some of the linkages just do not exist. So, for example, admission to the A&E department may be difficult to link to the laboratory data, to the imaging data. And so it was very difficult to link all that data together. And I think that linkages, the deep linkages, are going to be critical in the future for us to be able to get the best information as quickly as possible for these kind of serious, complex events.
At its heart, are you concerned there with data in hospitals and in the health service?
That's correct. So I think the data in hospitals particularly needs to be looked at and how it can be coded appropriately and linked to the primary care records so that we get a whole picture of what's going on with complex pictures, with complex syndromes such as this.
Are you aware of the review on health data done by Professor Kathy
I am
Sutlow
very much, yeah.
of November last year? Was that the field in which she was reporting? So she was focusing on data links in hospitals and at primary and secondary healthcare levels.
Yeah, data linkages are critical and linkages to the laboratory systems are critical, which are just not present at the moment.
Paragraph 2.17 on page 7 of this document. The Commission discussed whether risk mitigation was needed due to the presence of an alternative vaccine where these events are not seen at the same level, bluntly, Pfizer or Moderna. But it was agreed risk-benefit evaluation should be made without consideration of other vaccines. What did that mean?
So when we look at vaccines, we have to look at individual vaccines and the data associated with our individual vaccines rather than do comparative effectiveness. That's not within the remit of the CHM to do comparative effectiveness secondarily.
In the context of looking at benefit risk, one can readily see why you need to focus on the vaccine, which is giving rise to the problem. But wasn't the possibility or the existence of an alternative vaccine highly relevant to whether you could say to the public, all right, there's a worry about AstraZeneca, let's use Pfizer or Moderna?
So the benefit risk evaluation of each individual vaccine showed that the benefit far exceeded the risk for each vaccine at a population level.
For each of them separately?
Yeah, each of the... And there, if you looked, there was no direct comparative trials between the Pfizer and AstraZeneca. So it's very difficult secondarily to start comparing whether one is more beneficial than the other because the different populations were studied in those two different vaccine trials.
All right. By the 1st of April and the next CHM meeting, the Commission agreed or concluded that causality was still not established. You still couldn't show that there was a significant link. And the number of cases, whilst rising, was still at a level which showed it was extremely rare. I think the incidence was around about 4 in a million.
That's right.
Was that about right? So 4 cases of TTS and 1 million doses. But the Commission recommended that information on the risk nevertheless be communicated to healthcare professionals and the public. Why should that risk be communicated where you've concluded you cannot agree a causative connection?
So it is important to make sure that people are aware of the potential adverse effects which may be occurring so that they can make an informed choice as to whether to receive the vaccine. It is important for openness and transparency so the public are made aware of potential adverse effects. And I think on the 18th of March, Dame June Rain gave a sort of press conference with the Prime Minister, where she highlighted that MHRA was still investigating these rare cases of thrombosis, thrombocytopenia. So whenever it was possible, that we wanted to make sure the public was aware that these events were being investigated.
As at that date, the 1st of April in the CHM meeting, was consideration given to, at least if not not changing the conditions of authorization, but at least given to making a recommendation that AstraZeneca not be used under a certain age group?
So we did discuss that particularly, I think, on the 4th of April, looking at the age cutoff and whether there were particular age groups which were more likely to get these serious adverse events. And although does seem to be some age stratification, we sort of were getting, as I said, more data was trickling in. And then a few days later, we had data globally from AstraZeneca and the presentation from AstraZeneca, which showed more holistic data, and it was difficult for us to be able to say that there was truly an age cutoff that we could actually use based on the occurrence of the TTS.
But that Sunday, the 4th of April, I think Easter Sunday, when the CHM had convened on Easter Sunday to look at this issue, the committee, or the commission, recommended that the authorization under, as it happens, Regulation 174, be amended to reflect the fact that that risk-benefit balance was less favourable to the individual patient if they were under 40. That decision was taken on Sunday the 4th, before AstraZeneca provided, I think, quite a considerable amount of data, which it did on the 6th and 7th of April. Why wasn't that recommendation on age cutoff, in effect, made earlier on the 1st of April at that earlier CHM meeting, when you had instead decided to tell healthcare professionals about the risk and to better inform the public? Why was that change? Why wasn't that position reached earlier?
So as you can see, we were taking this particular condition very seriously, and we were ramping up meeting at short notice, not only the Vaccine Benefit Risk Expert Working Group, but the CHM, meeting on Saturday, meeting on Sunday, as data was trickling through. And the data was coming through, and we were asking the MHRA to get more information on individual reports to strengthen the amount of data that we had. And so it was very, very sort of, fluid situation, if you like, whereby we had to make decisions on days' notice based on amount of data that we were receiving.
And so is that why on the 6th of April, the CHM meeting, the Commission said, we haven't quite got there yet. We can't justify recommending or authorising, I apologise, recommending a change in the authorisation conditions for AstraZeneca to have vaccination only above a certain age, because the data is just not there to justify that step. Is that the nub of it?
Yeah. So we said, I think, on the 6th of April, the public should be made aware of this particular event.
And then finally, on this point, on this subject, did you give a press conference on the 7th of April along with Professor Sir Jonathan Fantam, Dame June Rain, and Professor Lim?
We did.
We'll just briefly look at that. 408 460, please. Pages 2 and 3, we can see, it's quite hard to spot, but on page 2, we can see references to your name. It might be further down the page. Yes, so Professor Sir Munir, over to you. Thank you very much. And you say, I've worked with the Commission on Human Medicines and the Expert Working Group separately to thoroughly review all the cases coming in on the Oxford AstraZeneca vaccine in the UK. We've taken into account a wide range of data sources. We've looked at information about usage, updated incident rates and incidence rates, and benefit risk comparisons for different populations by age and gender. You say both the committees, that's presumably the CHM and the Expert Working Group.
That's right.
Have spent almost 24 hours in committee reviewing these reports. You've scrutinised them. You've had independent adjudication by an expert haematologist. Is that the independent committee to which you referred? And we've worked with another group of haematologists to develop a case definition, and then you give the advice for pregnant women, those persons with a history of blood disorders, and those who experience cerebral or other major blood clots after the first dose. And that's right, where matters were left until, I think, May, when a positive recommendation was made that an alternative vaccine should be used for 30 to 39-year-olds. in outline.
Yeah, 7th of April, I think the JCVI made an announcement of 30-year age cutoff. And then in 7th of May, it was the 40-year age cutoff.
30 to 39.
Yeah,
All right.
and that was based on benefit risk rather than the risk itself, because the benefit in the under 30-year-olds was more marginal.
And is it essential, and is this what you did, to look at and to weigh up the potential benefits and harms for each age cohort? So if we have 497, 993, is this a diagram from somebody called the Winton Centre, which sets out in a bar chart the benefit risk analysis for each group? And just very simply, so I mean, I don't suppose I'm doing the issue sufficient credit at all, but we can see that the potential benefit for a 20-year-old of AstraZeneca vaccination is put at 0.8. The benefit for an over 60-year-old is put at 14.1, so massively greater benefit. In relation to the potential harm for a 60-year-old, the risk of TTS from AstraZeneca is put at 0.2, and therefore that's weighed against the massive benefit. But in relation to 20 to 29-year-olds, the potential harm is put at 1.1, which slightly exceeds the 0.8 benefit. Yeah. And that's the exercise that you did.
That's right. And this also depended on how much virus was circulating in the community at the moment. So the first graph shows you with low exposure risk, but then if you go down the graphs and so on, there's medium exposure risk and then high exposure risk as well.
So you've got to take into account incidence and transmission and risk of getting infected.
Absolutely.
All right. Lady, is that a convenient moment?
Certainly. You're warned that we take breaks, Professor, I hope. I shall return at 3:15.
All right.
Mr. Keith.
As a result of the Commission's examination of the issue of TTS, have you reached some views as to what lessons can be learnt in terms of making the job of the CHM easier in future and more efficient in relation to, firstly, getting more information from the yellow card scheme that better enables the CHM from being able to get into the reporter's medical records to find out more about the event they're reporting? And secondly, as you described, the linkage in between primary and secondary healthcare data.
That is correct. And the first point about getting access to the medical records and getting the detail that's required, particularly when you have a complex event. The third aspect, which I haven't mentioned, is that there should be accompanying research which allows one to be able to understand a mechanism behind that, which helps in terms of determining causality. And I, as a clinician scientist, was able to develop a consortium which allowed us to be able to start looking at the underlying mechanisms of why this was happening.
Now, turning to the concerns raised in the public sphere about the incidence of myocarditis and pericarditis. The Vaccine Benefit Risk Expert Working Group first discussed that issue on the 4th of February 21, Is it difficult in general terms to diagnose myocarditis and pericarditis?
Extremely difficult. It can be very heterogeneous in terms of the symptoms it presents with. And you do need laboratory tests as well as imaging as well of the heart to be able to make a proper diagnosis of myocarditis.
Can it be caused, can either condition be caused by viral infection and, of course, most particularly COVID?
Absolutely. The most common cause is viral infections, and often we do not know which virus has caused it. But we also had evidence during the pandemic that people with COVID infection were getting myocarditis.
To get some idea of the scale of myocarditis in the community, what sort of figures were there concerning admissions in England for myocarditis between 1988 and 2017?
So I don't have that data in front of me, but you may already have that data.
Saminia, you're right. I do. The figure which you've provided is around about 13,000. So 13,000 admissions for myocarditis itself in England pre-pandemic in that period. Following the pandemic, was there an article published concerning data from Denmark, Finland, Norway and Sweden in relation to myocarditis in the community?
That's right.
And what did that article show?
The data, particularly from Israel, was very helpful in terms of highlighting that the risk of myocarditis was higher after the second dose, and it was greater in younger men.
And did the article also say something about the outcome from suffering from myocarditis and comparing the outcome if you get myocarditis from COVID as opposed to myocarditis from vaccines?
Yes, most cases of myocarditis or myopericarditis were relatively mild after the vaccine, usually resulting in hospital admission of less than 2 days, whereas the myocarditis that was occurring from COVID was more severe and sometimes did, unfortunately, lead to fatalities.
So if you happen to have COVID and then you unknowingly present for vaccination and you get a vaccine and you then develop myocarditis or pericarditis, from that temporal link alone, you won't know whether or not it's from the vaccine or from pre-existing COVID.
Absolutely, we wouldn't know because there's no clear single test which can tell us whether it's related to the virus or due to the vaccine.
The expert working groups in the Commission and the Commission itself looked at this issue between 4th of February 2021 and the 23rd of June 2021. And although there was no evidence to suggest any fatalities in relation to myocarditis or pericarditis linked to vaccination, you recommended that the product information be updated to include a warning to the effect that such cases have been reported with the vaccines and also to highlight clinicians to the possible risk.
That is correct, and also to give the relevant advice to people who may have developed myocarditis in terms of exercise, but also what to do with regard to future vaccination as well.
Have you seen the expert report from Professor Prieto Alhambra?
I have, yes.
You may also have seen his evidence, I don't know.
Yes.
In his report, he quantifies, he highlights the amount of evidence, scientific and medical evidence in the public domain, and examines it for the quality, its quality, and in particular, whether or not that evidence appears to show an association between any of the COVID-19 vaccines and a very long list of conditions identified in the material before the inquiry. We've looked at TTS and myo and pericarditis, in relation to which he concludes there is good evidence, good quality evidence, to show at least an association without diving into the more complex question of whether there is a direct causative link, but at least an association.
Yeah, that's correct.
And your evidence is
Yes.
to similar effect. Do you also agree with what he says about the quality of the evidence establishing an association or lack of association in relation to Bell's palsy, Guillain-Barré syndrome, transverse myelitis, and acute disseminated encephalomyelitis?
So we looked at each of those conditions as the reports were coming through, and we did advise the MHRA to include them in the drug label with the Guillain-Barré syndrome, the transverse myelitis, and the ADEM, acute disseminated encephalomyelitis, in the AstraZeneca vaccine. With regard to the Bell's palsy, in fact, the clinical trial with the Moderna vaccine had shown there was an imbalance between the active and the placebo arm. And so we did actually include it from the beginning in the Moderna vaccine.
All right. And so is it your position, and you were looking at all these conditions at the time of the pandemic, that there is good evidence to suggest at least an association? So that obviously brings some degree of support and succour to those who believe that they've suffered these conditions as a result of vaccination. But you can't say whether or not they are directly causatively linked.
That is correct.
The issue of public information, patient information leaflets, and to a lesser extent, summary of product characteristics has been before the inquiry. A number of core participant groups have expressed concern that the patient information leaflets may not have been given to patients at the point of vaccination, or did not contain the requisite amount of detail so as to put them on guard in relation to any possible adverse event or risk associated with any vaccines. Have you formed a view about the level of information about risks that was provided to the public in the course of the pandemic? Do you think enough information about possible side effects was put into the public domain?
So when the vaccine is first authorized, one of the things that the CHM does in terms of its advice to the MHRA is to look at the summary product characteristics as well as the patient information leaflet and identify whether there needs to be more information included in there, whether it's in appropriate language to be understandable. So we look at that in detail. Obviously, as more evidence came through in terms of further adverse effects, we made suggestions or recommendations to the MHRA that the patient information leaflet should be changed to include new adverse events which were appearing. So over time, the patient information leaflet for each individual vaccine did evolve as more information came through. So I think that was appropriate and timely in all cases.
That's, of course, from the standpoint of the CHM in terms of putting the information into the public domain, period.
Yeah.
But there is obviously the issue as to the extent to which information you put into the public domain is acknowledged or read or picked up. Were you concerned during the pandemic that the objective picture which you were putting into the public domain was being crowded out by other forms of information, by social media, by just in the nature of these things, the messaging
Absolutely,
being taken on board?
We did discuss this many times as CHM, that it was really important that people who were being vaccinated did get the right information at the time, but obviously the misinformation, disinformation, social media was sometimes drowning out the correct information that should have been received by people.
In reality, was there anything you could do about that?
Not really, not from a CHM's remit at least.
Now, turning to therapeutics, I haven't asked you, but it's obvious, isn't it, that the CHM's remit went beyond vaccines and included therapeutics in the same way that the MHRA's does. The picture concerning the authorization and the putting into the public domain of relevant safety-related information is rather more complex in relation to drugs, isn't it? Because you've got new drugs, you've got repurposed drugs, you've got small molecule drugs, you've got neutralizing monoclonal antibodies. It's a more crowded field. But was there any significant difference in terms of the rigor or the level of scrutiny that the CHM applied to safety in the course of therapeutic examination as opposed to vaccine-related?
Absolutely not. We looked at every new medicinal product, which includes vaccines and therapeutics, with the same rigor in terms of quality, safety, and effectiveness.
Was your job made harder in the case of therapeutics because of a more fragmented, perhaps a less good picture from the clinical trial processes in terms of the degree of the quality of the science, the nature of the clinical trials, whether they were underpowered or under-resourced or under participated in, and also public and media reaction to the possible benefit of particular drugs.
Yes, so at the beginning of the pandemic, there were trials which were appearing, often in preprint servers before they were peer-reviewed and picked up by the press, which were of low quality, which led to a lot of information relating to the effectiveness of drug where probably the effectiveness did not really exist. And so it was really important to do some robust trials, and obviously that mantle was taken on by recovery in terms of the hospitalized patients, and then later on in terms of primary care by principal and panoramic trials in order to develop that robust evidence base, which was trial-based, which allowed us to be able to determine where there was true benefit.
Was the CHM asked to give its advice as to how this process of clinical trial for therapeutics be better managed, better organised, and perhaps better delivered in terms of the provision of data and information to you and the MHRA?
So the CHM has got clinical trials authorization as part of its remit. The MHRA can come to us in terms of advice. In fact, many of my colleagues, particularly on the Infection Expert Advisory Group and the Clinical Trials Expert Advisory Group, spent hours looking at clinical trial protocols at short notice and turned them around quickly so that all these clinical trials could be authorized within 2 days. And I want to thank them for that and acknowledge the enormous amount of work that they undertook. But also in terms of trials which were being undertaken, it was important that we were able to monitor what was going on. If there were particular issues which were arising, it was possible for the clinical trials unit at the MHRA to be able to bring them back to the MHRA to the CHM, for any advice.
The inquiry is aware that Professor Sir Martin Landry, and who was one of the co-leads of the recovery trial, along with Professor Sir Peter Horby, wrote a paper making a number of recommendations about how this process of clinical trial for therapeutics might be made a little more orderly. And he referred to things like having a clearer list of national priorities in terms of what sorts of trials should be allowed to proceed, having earlier phase 2 assessments so that you know earlier on whether or not a particular therapeutic is worth pursuing, having a greater use of randomized controlled trials, and having wider diversity, in fact. Are those all suggestions or calls with which you would agree?
Absolutely. I think it is important that we have a proper system to develop trials from the very beginning, phase 1 and phase 2, right through to the phase 4 trials, like recovery, robustly undertaken with appropriate governance framework, monitoring safety at all stages. The critical issue, particularly for the early phase trials, is to try to determine what dose is important. And maybe that wasn't done as well as we could have done it until later on when new platforms were set up, such as the Agile platform from Liverpool.
Obviously, in relation to therapeutics, where you're dealing with already authorized therapeutics, which may be open to repurposing, you don't need to go back and re-examine, do you, the issue of safety?
No, there should be a good safety database for repurposed medicines. However, what you can't exclude is the possibility that that repurposed medicine may interact with the disease, which is a new disease, and somehow cause other problems. So it is important to continually monitor the safety.
And of course, as the pandemic rolled on and as different variants of the SARS-CoV virus emerged, that made the issue of identifying suitable therapeutics harder because they may be less susceptible to protection against the virus. And also, some of the trials were taking place before the variants had emerged, so you couldn't tell whether or not the benefit would be maintained.
And that's particularly the case for the monoclonal antibodies.
All right. We needn't run through all the therapeutics. which were ultimately authorised on the advice of the CHM. But just perhaps to pick up one or 2 points, obviously you gave advice on and you reviewed and ultimately the use of molnupiravir and nirmatrelvir and ritonavir, Paxlovid, that those were authorised by the MHRA, and they were the 2 oral antivirals of which we heard from Mr. Gray. You reviewed and ultimately this was authorised dexamethasone. That was the highlight perhaps of the recovery trial process of which you've spoken. In relation to that, did the CHM become engaged in a debate with the leaders of the recovery trial as to whether or not there was sufficient evidence of benefit prior to you giving advice on its authorization?
So this CHM and the COVID Therapeutic Advisory Group did evaluate the role of dexamethasone, looking at data in terms of how steroids had been used previously in the for influenza. And the data in influenza in terms of effectiveness was not very strong in terms of whether it was helping. And what the CHM wanted to know was what evidence was the dose based on, for example, in recovery. And as we've seen in terms of recovery, doing further studies on higher doses, you don't get the same benefit with higher dose of dexamethasone or other steroids as you do with the 6 milligrams of dexamethasone. And so the CHM asked questions in terms of what the rationale was, not only for using dexamethasone, but also for the dose that was used in the trial.
And happily, recovery trial proceeded. The rest is history. They produced clear evidence of benefit, leading to its authorization and the saving of.
Yeah, and the recovery trial, as far as I recall, replied to the COVID Therapeutics Advisory Group, and we were happy for the trial to continue.
Evusheld was reviewed by you and authorized, and we've had a great deal of evidence about the process by which it wasn't ultimately made available. Could you just tell us, please, though, whether or not other regulators, other than the MHRA, did ultimately withdraw authorization for Evusheld on the grounds of lack of apparent benefit?
Yes, the FDA, Federal Drug Administration in the United States, did give it emergency use authorization, but as the variants changed and became more resistant, it withdrew that emergency use authorization.
Ivermectin was the subject of a considerable amount of debate in the public sphere. The debate about the benefits of ivermectin became, I think, politically highly polarized. Was it reviewed by the CHM in March and October 21? And did you give advice that there was insufficient evidence as to benefit?
Yes, we reviewed it several times, I think about 3 times in the different groups, including the CHM, and we looked at all the data. The data was not very robust, and we felt that there was no good evidence of effectiveness, and it should not be used outside a clinical trial setting.
And then finally, whether 2 other results from the recovery trial, Ronapreve, Casirivimab, Indevimab, and Tocilizumab, Roactamra, which you reviewed and then authorized.
Absolutely, and changed the label as a result of the results from the recovery trial.
There was another drug or therapy, hydroxychloroquine, which became similarly to ivermectin, highly polarized. Was the benefit of hydroxychloroquine and chloroquine looked at by the CHM?
It was on several occasions.
Was it looked at for the purposes of treatment as well as for possible prophylactic use?
So it was, yes, looked for both treatment and prophylactic use. There were trials going on, both for treatment in different patient groups, but also the prophylaxis as well.
The inquiry's expert, Professor White, has drawn the inquiry's attention to the fact that there was a study published in The Lancet which apparently showed not just a lack of benefit, but the possibility of harm in relation to hydroxychloroquine and chloroquine. As a result of that publication, did the CHM go back and specifically review clinical trial data in relation to hydroxychloroquine?
So that particular publication you're referring to, Mehra et al., I think, was eventually withdrawn, but that was one of the pieces of evidence we looked at initially, but also there were other trials which were smaller. The Mehra et al. Study, which was withdrawn, was an observational study, but there were other trials which had been undertaken at different doses. We looked at overall evidence in terms of benefits and safety.
And was there a particular commission meeting on the 21st of May 2020, but perhaps we'll just look briefly at it, 000409486, in which you looked at that article and the study which gave rise to the article in The Lancet, and you looked at other data about the risk balance and whether or not there was a benefit, and recommended, I think, reassessment overall as to what the benefit risk level was.
Yeah. So it was particularly important for hydroxychloroquine to understand what the safety aspects would be in this particular group, given that patients who are particularly vulnerable to severe effects from COVID were the elderly, vulnerable, and they may be on other drugs. Hydroxychloroquine is known to cause effects on the heart and other drugs which can be also interact with it to accentuate those effects on the heart. So it was important for the CHM to give advice to the MHRA to understand the safety aspects, how they were being monitored within the trials, and for the investigators to come back to the MHRA to reassure that the safety was being monitored appropriately. Patient safety was obviously paramount to CHM in terms of making sure that these drugs were not causing any unintended harms.
And if we look at this document, I think on the following page, please, 16, we can see you looked at a number of studies. You looked at the article in The Lancet and the study which underpinned it. You looked at the issue of risk benefit, and then over to page 17. Yep. You discussed what advice should be given, and you also particularly looked at the issue of whether or not you should speak to the investigators in the trials, or at least whether the MHRA should, to see whether or not the trial should be suspended whilst you look further at the issue of safety.
Yeah, so that was one of the things about pausing the trials, and the recovery came back to us with a robust justification. We also met with the chair of the Data Safety Monitoring Committee, who came to give evidence to CHM in terms of how they were monitoring the safety, and we were happy for the recovery trial to continue. We were waiting for the responses from the other hydroxychloroquine trials, but the recovery trial then reported that there was no benefit, and I guess the other investigators decided to not come back to the MHRA to restart their trials.
So the position that was ultimately reached was that I think whilst you were actually in session on the 5th of June, you received information that the clinical trials had stopped themselves. The trialists had suspended their own trials, and therefore there was nothing further for you to do. And so even though the press article, which had made claims against hydroxychloroquine, had been withdrawn, it didn't matter in the event because the trial lists stopped their own trials anyway. And told you accordingly. One of the trials was permitted to restart. Was that the Kopkov trial?
It was.
And was that the one with which the inquiry's expert, Professor White, is concerned?
That's right. I think he's principal investigator for that. That is a prophylaxis trial to give the drug at a lower dose to people who are for prophylaxis who don't have COVID, to prevent the occurrence of COVID.
But by the time that trial reported, things had moved on even further insofar as obviously the vaccine program had reached its fruition, and there were further variants out there in the public domain, and therefore there were further issues about benefit risk.
Yeah. So Professor White and his team did reply back to us and put in some additional measures to ensure the safety of the participants in the trial.
From all that, Samunia, you've taken care to put into your statement a number of recommendations, and I just want to highlight some of the most important ones. Obviously, my lady will be going through your statement with great care. In no particular order, do you feel that in the course of your Commission's functions, a closer working relationship and collaboration with the European Medicines Agency would have been more helpful, given that we have, of course, as a result of Brexit, withdrawn from that system, and in particular, it's the European community, not union system of vigilance?
That is correct. Irrespective of whether you're in a pandemic or outside a pandemic, it is important to get up-to-date information from regulators, not only within the European Union, but also outside the European Union as well. So you get the overall picture of what's going on with a particular medicine.
That said, was there any shortage of communication from your international colleagues, regulators and advisors on the issue of safety? I mean, it looks as if you're in touch a lot.
Yes, there were.
All right. Better access to linked up health data, you've addressed us on. Improvements to the yellow card scheme, you have said something about. And finally, this issue of dis and misinformation. From the viewpoint of the Commission, it must be of some frustration to see your carefully honed, scientifically based, objective information being put into the public domain and being swamped by other sources of information.
Very much so.
In reality, is there really anything that can be done about that, or do you just have to keep on pronouncing the message?
I think providing the message to the public and is very important, and continual reminders of the true facts of the benefits and risks of the vaccine.
Thank you very much.
Just a few more questions for you, Professor. Ms Douglas, who's that away, has got a couple of questions for you.
Thank you, my lady. Good afternoon, Samunia. I act on behalf of clinically vulnerable families who represent the clinically vulnerable, the clinically extremely vulnerable and the immunosuppressed. The vulnerable people that CVF represents are at a higher risk of severe outcomes from COVID-19. We've heard a little bit this afternoon about the various vaccines and therapeutics that were authorised on the advice of the CHM. And my question is this: would you support the development of a more diverse portfolio of vaccine formats and antivirals, both as part of future pandemic preparedness plans and during what others have described as peacetime, to ensure that clinically vulnerable groups are adequately protected?
Absolutely. I think it's really important to make sure that we have good therapeutics and vaccines for the whole population, those who are clinically vulnerable, as well as in different groups as well. So it is important elderly participate in these particular trials to make sure particular vaccines and therapeutics are relevant for that group, particularly in COVID, that they were the most vulnerable. But if you look at other infections, such as influenza, maybe the children are more vulnerable, to make sure that relevant groups are take part in trials, so we develop those therapeutics and vaccines for the relevant groups.
Thank you. And if I may just expand on that, why is it important to have that breadth of formats?
Well, if you take the vulnerable in terms of the immunosuppressed, giving a vaccine, not many were involved in the initial trials, so we do not know whether the vaccine would be effective. So we now know that the vaccine does provide some efficacy, but is not as much efficacy as in the non-immunosuppressed and so on. But booster doses help in terms of improving that vaccine efficacy. So it's important to ensure that we have the relevant, diverse group of people involved in the therapeutic trials and the vaccine trials to make sure that we have adequate information that covers the whole population.
And thank you. If I may, Melly, just because it just went to the question about the formats of the vaccine, the point I was getting to more was that there are, obviously, as we've heard, the mRNA formats, protein-based formats, and it's whether whether you would support a diversity of that, of having a range of formats of vaccines and antivirals.
Absolutely. So, it's very, very important not to just rely on one particular platform, but to have the protein-based platforms, the adenoviral platform, mRNA platform, plus other types of platforms which may be coming through. But also different, as we move forward, also different ways of being able to administer vaccines. For example, the ones we've been using has been intramuscular, but nasal vaccines are being developed, which is going to be important. So having a portfolio of vaccines with different routes of administration is going to be very important in terms of preparing for the next pandemic.
Thank you.
Thank you,
my
Ms
lady.
Douglas. Ms Morris. Ms Morris is over that way. Please make sure your answers go into the microphone.
Okay.
Ms Morris will understand if you don't look at her all the time.
Thank you, my lady. Samanya, I asked questions on behalf of the COVID adverse reaction and bereaved groups. These are groups who represent those who were injured by the vaccine or lost loved ones following their acceptance of the vaccine. In your evidence, you've stressed the importance of having more healthcare data in relation to those who suffered a suspected adverse reaction. Do you accept that having patient medical records as one of the sources of that post-authorisation safety monitoring depends largely on what is recorded in that record by the healthcare provider as to whether the symptoms may or may not be connected to the vaccine, for example, before you even get to the triangulation point that you made in your evidence?
So, I'm sorry, I'll just speak into the microphone. So it is really important that adequate data is entered into the medical record. So if you look at primary care data, it may be coded or may not be coded, and so one can track it easily. But as we develop new tools, such as artificial intelligence-based tools, natural language processing, it may be possible to actually look at the textual data, which is unstructured data, to be able to get that adequate information. If you look at hospital data, clearly if a vaccine has resulted in an adverse effect which is severe enough to lead to hospital admission, then that should be recorded and coded so that we can make that linkage between the vaccine and the admission to hospital.
Again, dependent on what's put in, what is coded by the practitioner into the records in the first place.
Absolutely, and coding is getting better, but it's not perfect. I think that we do need to think about how we can improve coding in real time so that we get that information quickly coming through to the regulators, to the health authorities, so that we understand whether the harms and benefits are occurring with new medicines as well as established medicines.
That's helpful. Thank you. Thank you, my lady.
Thank you, Ms Morris. Thank you very much indeed, Professor. Extremely grateful to you. You and your colleagues obviously worked extraordinarily hard to try and ensure the safety, or monitoring the safety of vaccines for the protection of the public. And I know that we're all indebted to you. And thank you for the help you've given to the inquiry and for giving evidence today.
Lady, that concludes the evidence for today.
Thank you. 10 o'clock tomorrow, please.
All right.